Hello everyone and welcome to Boundless Dentistry. In this video we'll talk about endodontic and periodontic lesions, like how an endodontic lesion can affect the periodontium and how a lesion from periodontium can affect the endodontium. So let's get started. Okay, so on your left hand side you can see a picture of a tooth and its surrounding structures. Note the gingiva is reddish as compared to the normal color of the gingiva, which is coral pink. On both sides the gingiva is red, which means the gingiva is swollen, which finally means that the gingiva is inflamed. So if you use a periodontal probe over here and you check the depth by inserting the periodontal probe over here, it will most probably be above 2 mm. 2 mm is the normal cutoff value for the depth of the pocket. So when you insert the periodontal probe over here, the depth of the pocket will be greater than 2 mm. And this is not differentiating point for gingivitis or periodontitis. For you to differentiate between them and reach to a diagnosis, radiograph is required. So if you on a radiograph you see bone loss, it means that the patient is suffering from periodontitis, and if there is no bone loss, then simply the patient has gingivitis. Now on the right hand side you can see a tooth, and on this tooth there is a carious lesion, which you can see here with brown color. This is a carious lesion. Now this carious lesion has penetrated enamel dentine and is invaded the pulp. Now as it has invaded the pulp, there is inflammation in this pulp. Now as inflammation continues and it is not resolved, it leads to this infection, or you can say lesion, over the root area of the tooth, and this is known as periapical lesion. Periapical means that around the apex of the tooth there is a lesion, so it's called as periapical lesion. So this is an endodontic lesion and this is a periodontic lesion, both starting having their own origins. So let's talk further about it. Okay, now talking about communication routes between pulp and periodontium. As the tooth develops, there are certain communicating channels that are formed that help in communication between the pulp and the periodontium. So there are mainly three routes of communication between these two. First is, and the foremost important, is this one. This is known as apical foramen, the most important route of communication. Secondly, we have these which are known as lateral, or you can also call it accessory canals. And lastly, we have dentinal tubules. Okay, so there are three routes of communication between pulp and periodontium. First is lateral canals, then we have apical foramen, and then we have dentinal tubules. In all of these three, the apical foramen is the most important route of communication between pulp and periodontium. Now, for example, there is a pathology in the pulp where there is a large carious lesion or restorative region which has invaded the pulp, and now the pulp is inflamed, and if the inflammation is not resolved, bacteria starts to grow and grow, and mainly anaerobic bacteria is responsible for irreversible pulpitis. So as the pulpitis moves forward, it then invades the apical tissues like this from here. It invades the apical tissues of the root, and now when it invades the apical area of the root via the apical foramen, the periapical lesion occurs, which results in the destruction of the PDL periodontal fibers and resorption of the surrounding bone as well. Now talking about dentinal tubules, normally dentinal tubules are not exposed to the oral cavity because they are surrounded by a thin layer of cementum that is present over here, but in some cases the cementum might be missing or it has eroded away. For example, in some cases the cementum is congenitally absent, so the dentinal tubules are exposed and the bacteria invades through it and affects the pulp. And in more cases, for example in deep curettage, the cementum is thinned more than it should be, so this also exposes the dentinal tubule and provides a route through which the bacteria invades the pulp. And lastly, the lateral canals, although their significance is not as much as compared to apical foramen and dentinal tubules, but they are also uh, present as a route for the bacteria and irritants to invade the pulp or invade the periodontium, vice versa. So these are the three routes through which pulp and periodontium communicate with each other. Okay, so now talking about the effect of endodontic lesion on periodontium. So now you can see that there is a carious lesion present on the crown of a tooth. This can also be restorative or even in some cases fracture tooth, when tooth fractures and exposes the pulp. So now in this case carious lesion is present, and another case carious lesion penetrates the pulp, inflammation starts. Initially it's reversible pulpitis because if the lesion is removed, pulpitis resolves, but most of the cases patients do not visit the dentist when the pain is very mild and very intermittent. So they normally visit the dentist when the pain is excruciating and for a very long duration. So at that stage, irreversible pulpitis develops. So in this case also, irreversible pulpitis has developed, and the lesion then progresses towards the apex and results in an periapical lesion. Now note, in irreversible pulpitis, mainly anaerobic bacteria are the main causative factors, and their irritants, they mainly lead to this lesion. Now as the bacteria are present in the periapical lesion, they then move towards the periodontium like this. And when they move towards the periodontium, this results in the inflammation in this periodontium, or you can mostly this gingiva and the periodontium as well. It results in inflammation of this area. Now the main pathogenic mechanism by which this inflammation starts from the pulp and cause its effect in periodontium as well is when these anaerobic bacteria, they attack the pulp and they release their mediators such as interleukin 1. Let me write it down. Mainly interleukin 1 and interleukin 2, TNF alpha. These are the main inflammatory mediators which are released by these bacteria, and these are also released by the host cell in order to contain the bacteria. But this is not possible because tooth is a very small chamber and it cannot handle edema, because when these factors are released, edema is present, and in this closed chamber edema cannot be tolerated. So when it cannot be tolerated, the hypoxia is created, and this favors the anaerobic bacteria, and then this leads to promotion of the pathology, and from that pathology periapical lesion occurs, and the periapical lesion, then the bacteria travels upwards towards the periodontium, affects the gingiva, affects the cementum and the bone. The gingiva is inflamed, the bone starts to resorb, and you can clinically feel mobility in that tooth. So this is how an endodontic lesion affects the periodontium. Root canal treatment, which consists of cleaning and obturation, mainly results in resolution of the endodontic damage as well as the periodontal damage, but we will discuss this in a short while. Endodontic lesion most frequently results in a periodontal lesion, but same cannot be said for a periodontal lesion causing an effect on the endodontium. And many scientists believe that in most of the cases, the periodontal lesion doesn't affect the endodontium because endodontium has protective cells like white blood cells, mast cells, which protect the negative effects of periodontium towards the pulp. But anyhow, it can result in. So, for example, there is a plaque and calculus deposited on this tooth. Like for example, there is here, let me draw it with yellow. We have plaque and calculus deposited over here. Now below this plaque and calculus, bacteria starts to divide, and anaerobic bacteria then take the charge, and when they do so, the gingiva is inflamed, and when the gingiva is inflamed, slowly it leads to periodontal disease. Now when this leads to periodontal disease, the bacteria then moves downward, downward, and then invade the endodontium or the pulp, and this is how a periodontal disease affects the endodontium. The mechanism of pathogenesis for this is pretty much same as we discussed before, but since the pulp has protective effects, in most of the cases the periodontal disease does not affect the endodontium. Now on your right hand side you can see list of bacteria. These are the main bacteria that are involved in the periodontic lesion, which then leads to or can lead to uh, endodontic lesion, but this is not very frequent. It's rare, if you can say. Now, these are few key points for how you can diagnose whether a lesion is periodontic or lesion is endodontic. So, for example, if a patient comes to you with no significant pain at all, but clinically you can see plaque, calculus present on generalized teeth or in few segment of teeth, and you may also suspect gingivitis and periodontitis, but you cannot tell that 100% correctly without a radiograph. So taking a radiograph is very important. And on radiograph, if you see bone loss either horizontally or vertically, then you can definitely say that the patient is suffering from periodontitis. Okay. On the other hand, a patient comes to you with severe pain, severe excruciating pain, which requires analgesics, along with you can see a tooth that has a carious lesion or a restorative, or even the tooth is fractured, and even the tooth is discolored. Now the tooth is discolored because as the carious lesion invades the tooth, dentine and enamel breaks down. So as it breaks down, the color of pulp reflects. So this leads to discoloration of the tooth. And when you do a radiograph, you can see apically a radiolucency. So if all these features are present in the tooth, then in a patient, then you can say the patient has an endodontic lesion. So this is how you differentiate between a periodontic lesion and an endodontic lesion. And if in some patients both of the features are present at the same time, you can say that the patient is suffering from a true combined perio-endo lesion. That's what you call it. Now there are certain clinical tests that are performed on a tooth so that it can aid us in further making our diagnosis stronger and accurate. The first is the vitality test. Vitality test is simply a test which is used to know whether the pulp is alive or not. For example, if a tooth has a necrotic pulp, then it will have no response to thermal or electrical stimuli. And in contrast to a tooth which has a periodontic lesion, the vitality test will often be uh, positive because the pulp is alive. Secondly, talking about palpation, when you use the your fingers pulp and you press it on a tooth, and the patient feels sensitivity, then it can either be gingivitis or periodontitis. And if palpation is performed on the apex of a tooth with a pulp necrosis, indicates the presence of periapical lesion. And then sometimes clinicians also perform percussion, which you can see over here. This is a dental mirror, and with the dental mirrors end, it is used like this to percuss the tooth. If tenderness is heard clinically, then it is known as positive tenderness to percussion, which means that there is some sort of inflammation in the periodontium. This is not a very sensitive test, but it is used by some dental surgeons to indicate that there is some inflammation in the tooth. And lastly, talking about probing. Now this is a probe, periodontal probe. When you insert it into the tooth around 6 surfaces of the tooth, 3 buccally and 3 lingually. If the probing depth around the tooth is greater than 3 to 4 mm, then it definitely means that there is some compromised periodontium of that tooth. It can either be generalized around the mouth, or it can be even to a single tooth or a segment of a tooth. So these are the clinical tests that we perform in order to strengthen our diagnosis and make a much more accurate diagnosis, because our accurate diagnosis leads to an accurate treatment, and then this is beneficial for the patient. Okay, so now there's a patient with a primary periodontal defect of endodontic oration. That means that the lesion started from the pulp, which you can see over here. There is a carious lesion, and this carious lesion invaded the pulp, and down it formed the periapical lesion, and this periapical lesion traveled up and affected the periodontium. So the lesion is periodontal lesion with an endodontic origin. So how will you diagnose it? First, we'll diagnose it by simply by probing it. We will probe it to check the probing depth, and the probing depth will be greater than normal, obviously. And then we use radiographs. In radiograph, you will see that there will be periapical radiolucency, and if the lesion has been long standing, then there will be bone loss horizontally or vertically. This means that the lesion started from the pulp and then it involved the periodontium. So this is the primary periodontal defect of endodontic origin. Now how will you treat it? The first and the foremost important thing is perform root canal treatment in order to resolve the endodontic lesion. When you perform the root canal treatment, the endodontic lesion will automatically resolve, and when this will resolve, the bacterial load will decrease, and when the bacterial load will decrease, the bacteria in the periodontium, they will also decrease. So this will automatically resolve the lesion. Sometimes periodontal treatment can be required, or in many cases it is not required. So if it is required, you can do scaling and root planing if required, but in many cases root canal treatment is sufficient enough to save the tooth. Okay, so now in this case, primary periodontal defect of periodontic oration. That means that the bacteria is present only over here because of the formation of calculus over here, plaque calculus deposited over many years of time, and when this deposited, this leads to favorable condition for bacteria, especially for the anaerobic bacteria, because they are the main pathogenic factor for causing periodontitis. So these bacteria then proliferate and then eventually gradually lead to gingivitis. The gingivitis finally leads to periodontitis. Now how will you diagnose whether the patient has developed periodontitis or not? The most important thing is radiograph. And in radiograph, if the patient has periodontitis, you can either see horizontal bone loss or vertical bone loss, and of course you will also do probing around all teeth that you are suspecting of having periodontitis. You insert the tooth and then you check for the pocket depth around all of the tooth. Now how will you treat this? The treatment is quite simple. Basically it depends on the severity of periodontitis, like is it mild, moderate or severe, but the first line of treatment in most cases is scaling and root planing. There are also other treatment options available, for example tissue regeneration, gingival grafts, etc. We will discuss that when we talk about only the treatment options that are present for periodontitis, but for now you just have to know this. That's it. Like we have talked before, an endodontic lesion of periodontal origin is very rare because of the defensive system of the pulp. Periodontal lesion invading the pulp and causing its pathology is rare, as we have talked before, but in sometimes, very rarely, it can occur. So how will you diagnose it? First you will do probing, which is the standard method. Then you will do a radiograph, and in radiograph you can see a bone loss, and if there is some pulpal pathology present, you might be able to see a periapical lesion, but this is very rare. And the treatment option is very simple, because in most of the cases the pulp is not involved, so you will not do root canal treatment. no RCT, which RCT means root canal, because the pulp is not involved in most cases, but there are exceptions that if the pulp is involved and it cannot be saved, then you can perform the root canal treatment. The standard treatment is scaling and root planing. This is the standard treatment for this pathology. That's it. Lastly, talking about true combined endo-perio lesion. Now, what does it mean? This means basically that on one hand, you have this large carious cavity which will lead to an endodontic lesion, and at the same time, the gingiva is inflamed and the pocket depth is increasing, which will also lead to a periodontic lesion. So, these both activity, the periodontic activity and the endodontic activity, is occurring at the same time. So when it occurs at the same time, it is known as true combined endo-perio lesion. So how will you diagnose it? We will diagnose it by firstly doing probing to check the pocket depth, and then we will perform radiographs to see how much bone loss has occurred and if there is any periapical lesion. Now, the treatment options for this case is firstly you perform the root canal treatment, RCT, to resolve the endodontic lesion, and then you perform scaling and root planing to resolve the periodontic lesion. Because firstly we discussed that a lesion originating from endo affecting the perio, then we discussed a lesion of perio affecting the endo, and now we are finally discussing a true combined endo-perio lesion. This is called as true combined because both endo and perio lesions are occurring at the same time, not at a different time. They are occurring simultaneously, so that's why it is called as true combined endo-perio lesion. For diagnosis, you do probing and you take a radiograph. Radiograph is like the most basic test that you perform when a patient comes to you for any complaint related to dentistry. Radiograph has to be performed. There are very few exceptions where you don't perform radiographs, but at most of the times radiograph is performed. And in this case, the treatment, root canal treatment to solve the endodontic problem, and scaling and root planing to resolve the periodontal lesion. So that's all about endo-perio lesions and its relation with each other. I hope you found this video useful, and if you like this video, please like, share, and subscribe. If you have any queries, please comment in the section below. Thank you very much. See you next time.